Thank you, Dr. Greenberg. Just waiting a moment for the slides to show up. Here we are. Awesome. All right. So again, like yesterday, I'm excited to be here to tell you about some very new information we really haven't had the chance to share yet. And quite honestly, we're still processing some of the results. What you'll hear about today are preliminary findings, so I want you to know that as we jump in. So I thought the Dunning-Kruger effect would be a good way to set the stage for the foundation for our study. I don't know if any of you have heard of this before. Dunning and Kruger refers to two social psychologists at Cornell who talked about a story from 1995. Mr. MacArthur Wheeler was caught after robbing two banks. Easily identifiable because he didn't wear a mask or any type of disguise. Instead, he covered his face with lemon juice. And he thought this would make it invisible to the surveillance cameras. He was wrong. He later explained that lemon juice was a critical ingredient in invisible ink. So that was his thought. So at its core, this effect illustrates how when we don't appreciate a full picture, or if there's ignorance, we can get into trouble. So the unknown unknown. So in rare diseases, dogma predominates and can be perpetuated over time. We've talked about this weekend. This idea, whatever you get by year one of recovery is what you're going to have. Or based on this MRI, your child will never walk again, or some other global statement. Transverse myelitis is a spinal cord disease. So how do we defend against this? Well, we work as a team, and we've emphasized that a lot throughout. We bring together experts who can supply their lens to the problem and to the question and help us really research these conditions and answer important questions. I think very importantly, and this is what has happened for me over the last 8 years, is we allow our patients and our data to teach us. So we have to remain humble as we do this. I mentioned this research journey yesterday, and I'm going to take you through in a little bit more detail about how we got where we are today using brain imaging to study TM. So we opened our clinic many years ago. I was interested in looking at, from a research perspective, these outcomes associated with MS and ADEM, these conditions you could readily see on an MRI scan here as depicted on the right. So my thinking was we would use transverse myelitis, that group, as a control to study MS with a very simple, straightforward hypothesis, right? That patients with MS experience more cognitive problems as well as school problems due to the chronic nature of the condition working on the brain. So we administered a screening battery that was designed to measure all of these domains. This is standardized testing, like Dr. Wang just talked about. And we had everybody complete the same brief battery of tests. So this served as a screener to look at areas that we thought were vulnerable in demyelinating conditions. And we were right in some ways. And as we talked about yesterday, we saw that our patients with MS were in fact experiencing greater cognitive impairment in some areas. This was happening at a statistically significant level, but we saw the same rate of school problems in each of these patient cohorts. And as a pediatric neuropsychologist, that's a big flag for me. If there are school issues, that tells me something is going on. And to see equal rates of that in these conditions really had me take a step back, along with the rest of my team. So we wanted to think about what was known about cognition and transverse myelitis. We found two very excellent papers that really talked about clinical characteristics, functional outcomes associated with transverse myelitis. But in the first one by Pidcock and colleagues, there was no mention of cognition or psychological problems or any kind of outcome along those lines. There was another study by Trecker and colleagues that surveyed patients and parents who were attending a camp for individuals with TM. What caught my attention was 90% of those surveyed said they would have liked to have had consultation with psychiatry as part of their care. And that stands out to me as signifying that there must have been some underlying emotional difficulty, which makes sense, especially with all that we know today. There were qualitative reports. They give a nice discussion about cognitive and psychosocial problems or psychological problems, but there was no data. And the scope of that study wasn't meant to document these functions through standardized testing. When we looked at our own clinic data, we saw that almost 42% had been referred for therapy, for some sort of mental health service. Close to 30% had been referred for a full neuropsychological evaluation, meaning that they, quote unquote, failed that screener, the battery I showed you earlier. So those are significant numbers there that tell us there's more going on, right? So we were able to publish this work several years ago, and what I want to highlight for you here, I've listed percentages of impairment found in the group that we looked at, all patients with pediatric TM. Attention problems really stood out to me, both in terms of performance-based testing, 41% showing deficits in that area, as well as parent report of their child's attention problems in close to a third. There were also some problems noted in memory. These were not things I expected to see in a condition that was restricted to the spinal cord. So we were left with more questions. And right now, we're still continuing to explore these potential explanations of cognitive dysfunction in the context of pediatric TM. So we wondered, could this be medication side effects? Could this be mood-related symptoms that are associated with the cognitive problems? Or maybe it's fatigue. We have a very astute audience here who already asked some of these questions yesterday, and so I had the chance to address this in part. When I looked at that cohort, and I also looked at their medication use, the folks who were having cognitive issues were not the same individuals that were on medications. And the ones with cognitive issues were also not the ones that were experiencing mood problems. We still have a question on the table about the role of fatigue, and I spoke about that yesterday. So we still are looking into how fatigue is undermining the cognitive functions of our individuals with TM. But the other big question, could there be brain-based pathology in transverse myelitis? So the theories that would be behind this idea relate to the inflammation associated with TM that is in the central nervous system. So this is not readily apparent on MRI with our traditional techniques. We wonder if the inflammation that's in the spinal cord could lead to changes more distally up into the brain, and similarly, could it affect the tracts that go between the spinal cord and the brain? Can neuropsychological evaluation show problems that cannot be seen on imaging? I think so. And so it's through the testing that we did that we were able to illuminate this problem. There are probably many more things we don't know that we hope to discover as this story unfolds. But if we do identify brain-based pathology in the context of transverse myelitis, this could really dramatically change things in terms of our conceptualization of TM, but also in terms of the treatments. So this is where the TMA comes in. Who gave us the opportunity. They partnered with Consano. Some of you may have seen this. This is a crowdfunding organization who helped us raise funds to conduct a pilot study using brain imaging. And this slide serves as an acknowledgement slide to both the TMA and Consano for making this work possible. So I want to tell you about our pilot study design. I'll give you a little bit on preliminary results. We've mentioned that the scans that we're doing clinically are not readily catching anything obvious as far as what might be happening in the brain. So we've worked very closely with our colleagues in radiology to come up with a sequence where we're able to look at the brain in some different ways than we would do in the clinical realm. And it helps us understand and visualize possible damage associated with inflammation and to look at how the brain is networked. And I want to say I am not an expert in imaging or radiology, so I rely heavily on my colleagues with that expertise. So our protocol lasts about 4 hours or so. They come in for a cognitive test battery with me that's about, or with someone from my team, that is about 2 hours long. We're also looking at the eyes and the optic nerves using optical coherence tomography. And then we're doing the MRI of the brain. Our participants are not sedated when they go through this. We need them to be able to lie still for the imaging. They are allowed to watch a movie or listen to Pandora, so that really helps a lot because our sequences last about 45 minutes to an hour. So we are recruiting through an IRB-approved study, just so you get a sense of the participants. They have to have a diagnosis of TM. We're also recruiting siblings, which I think has ended up being kind of fun and enlightening for the siblings who haven't been through similar medical procedures like an MRI or our testing. The age range is 8 to 18. They need to have IQ of 78 or above to make sure that they are generally globally cognitively intact when it comes to intelligence. English must be the primary language, and the reason for that is because our measures are normed on individuals for whom English is the primary or first language. So we are not enrolling anybody that needs sedation for the MRI, as I mentioned a while ago. Also, we are not taking anyone with other neurological problems like traumatic brain injury, epilepsy, or stroke, because we wouldn't be able to be sure we weren't picking up on abnormalities associated with those conditions. We're also making sure that for anyone we enroll at the time of the scan and the testing, they haven't had any acute symptoms or steroids in the last 30 days or so. So we are planning to enroll 20 participants total, 10 with a diagnosis of TM and 10 sibling controls. So we're at 13, so we're well on our way. The age range for each group is quite similar, 10 to 18 and 10 to 17. Most are female. And in case you're straining and trying to figure out what this movie is, any guesses? This is Harry Potter. So this was the movie choice of one of our participants who got to watch while being scanned. So in terms of preliminary findings, you see the caution symbol here. We always want to use caution when we're talking about very small numbers. We have not been using a lot of statistical techniques at this stage. Even with our target numbers, those are quite small. So we just want to use a lot of caution as we talk about the next preliminary findings. So we have done some interim analysis, as I mentioned, that we've just received very recently. And our data is already showing potential regions of interest that differ between patients and controls. Here's an image here highlighting the thalamus. And this is a structure functionally that's important as a sensory relay station. I'll give you an example. Auditory information passes through this area. And I'm going to tell you why that's important in a second. Over time, we have recognized that the role of the thalamus in cognition turns out to be quite important. So other results are suggesting a possible correlation between cognitive testing in an area that has previously been found to be problematic for individuals with TM, and this relates to auditory attention and memory. So when we think about the thalamus as a sensory relay station regarding this auditory information, this might make sense. And as I said at the very beginning, we're still digesting this, still processing this. These are not by any means final findings or conclusive statements that we're making here. So with that, I say stay tuned. We will have more to come on this. I want to acknowledge the folks back in Dallas who have contributed to this work, including our team from radiology, Dr. Greenberg, and then folks from neuropsychology. Cole, out of that group, is the only one here today, and then study personnel. Patricia Plum is around here somewhere. So we couldn't do it without the team, and I think also having a team helps us challenge each other, and each of the things that we contribute really allow us to highlight different aspects of how a condition may manifest. So we're very excited and grateful to have the opportunity to be able to continue this work. Thank you.